Now, so I know that you're in your second term of your medical education, and probably so far you've had some introduction to cranial nerves. So Dr. Cooper evidently did a bit about testing cranial nerves, talked a little bit about testing, and probably when you've done gross anatomy, Dr. Coey, did he do a little bit of cranial nerves then? Okay. So now we're going to do kind of the neurosciences. So how do these nerves work? Basically, that's today. All right? Now, why do I think these things are so darn important? What's my philosophy behind cranial nerves? Because I really believe that this is one of those concepts for your practice, that it doesn't matter what you end up doing, you're always going to be calling on your knowledge of cranial nerves. Because when you meet a patient for the very first time, before you even extend your hand out and say, good afternoon, this is Smith, I am Dr. Graham, you're looking at the face. Us human beings are fixated by the human face. Our eyes are drawn to even the slightest imperfections about positioning of eyes or eyelids or the tone, the symmetrical tone of a face. So it doesn't matter if you go on and do psychiatry, surgery, general practice. Every time you meet a new patient, before you introduce yourself to him or her, you are assessing their cranial nerves unconsciously, because that's what we all do every day. And you know that's true, and let's be honest with ourselves, you know that's true because when you walk through a crowd of people, right, our eyes are constantly scanning, and you're, somewhere in the back of your brain, you're constantly going, no, 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 you don't know that person. And then all of a sudden, in a huge crowd of people, maybe an unexpected face of someone you know comes up, and boom, immediate recognition. And if there was something wrong with that person's face that you know very well, you would see it instantaneously. So cranial nerves are absolutely important. And you have to know the 12 cranial nerves. You have to know their names. You have to know their Roman numeral designation. You have to know their basic function. And you have to know a little bit about the anatomy that's associated with it. I mean, there's just no two ways about it. So, if you go on and do psychiatry, chances are, motor and sensory pathways are not going to be as big as if you were a neurologist like Dr. Cooper, right? But even psychiatrists are looking at people's faces, right? Is there something wrong? And so, critically important. So, you've had an introduction to them. So now I'm going to make sure that we have a clear understanding about their names, their function, all this good stuff. All right. First thing, there are 12 pairs of these cranial nerves, and 10 of the 12 are associated with that structure I just mentioned, the brainstem. And the brainstem is composed of 3 parts: the midbrain, the pons, and the medulla. Collectively, you can say the brainstem, but as long as you recognize that within this structure there are 3 distinct components: a midbrain, the pons, and the medulla. And the pons and the cerebellum working together as a unit. Oh, sorry. So I certainly, as I said, this is not a neuroanatomy course. If this was a neuroanatomy course, you could darn bet that I would have some exam questions showing you this kind of image and pointing to one of those little rootlets and asking you to identify which cranial nerve rootlet this is, right? I'm not going to do that. But what I do want you to recognize is that these rootlets are in fact the cranial nerves, and that they are in fact associated with the brainstem. So the anterior surface of the brainstem. So this is kind of the thing, this is the front of it. And so we've got the midbrain there, the pons, and the medulla. And these little rootlets you see are the actual cranial nerves, the pairs of them, left and right, that are associated with the brainstem. And then there are 2, the top 2 cranial nerves, which are associated with the higher parts of the brain itself.
Now, it's important that one of the modality things we have to understand about these cranial nerves is the modalities that they convey. And when we think about that, it's predominantly going to be sensory and motor information. So within these nerve rootlets, you know, some of them are completely motor, some of them are motor and sensory. But again, it's just that you recognize that these, the 10 of the 12 pairs of cranial nerves are intimately associated with the brainstem. Now, you know, and lots of people have ways of memorizing these things. There are lots of mnemonics out there. Some of them are incredibly naughty, and some of them are completely politically incorrect, none of which I will tell you. But however you remember these 12 cranial nerves is up to you. But the whole idea of a mnemonic, right, is something you do over and over again, right, to commit it to memory. And the day will come where you don't have to do that anymore, right? That you just know that the 5th cranial nerve is trigeminal, and that the 11th cranial nerve is spinal accessory. So you won't have to do that. But in the meantime, getting there, whatever works for you is fine with me. So you can find these things on Google. I'm not going to tell you any of them, but it's just a little something here about mnemonics. Cranial nerves are recognized by two things: their proper name and a Roman numeral. So you can say cranial nerve 5, that's fine. But if you don't know the proper name, the cranial nerve 5, then it defeats you knowing cranial nerve 5. You have to know the proper name and the Roman numeral designation for all. Fortunately, when these names were being given out, people thought, you know, all of these names make sense, right? So they actually do convey very specific information about what that nerve does. So you look at like a word like optic. Well, the eye is conveying the visual information. Oculomotor, the movement of the eye. Facial, something to do with the face. Hypoglossal, something to do with the tongue. And what's important for you to know is what these nerves convey. What is their information? What are they sending to these structures, or what information are they bringing back? So, our 12 cranial nerves are, which is not shown here, olfactory 1, optic, oculomotor, trochlear, trigeminal, abducens facial, vestibulocochlear, glossopharyngeus, vagus, spinal accessory, and hypoglossal, all of which have their Roman numeral designation. So, what I showed you here, those rootlets there they are all labeled here. And I will not ask you to identify which rootlet is what. Having said that, though, I am going to give you a couple of tricks that if you were ever asked on your Step 1 exam, if you were shown a brainstem, I'm going to give you a couple of tricks to actually make an incredibly good, educated guess as to what the correct answer should be. So, as much as I really like the schematics that I found in this textbook, I really, really like the charts. Because what the charts can do for you is that you can study with them and, for instance, cover up, you know, the first column, or the second column, or the third column, whichever you wish to do. And ask yourself, you know, what is the proper name of cranial nerve 1? What does it do? What is its main function? And so these charts are really helpful for you to start to learn and commit all this information to memory. And functional memory. Because as I said, you're going to be using, you know, your knowledge of cranial nerves over and over and over again. So, we think about what they're doing. Cranial nerves, by their very definition, have to do with what? The head. Right? The head, the neck, extends a little bit out, or a couple of them. But predominantly we're thinking about the head and neck. So when you think about the head and neck, what activities would you want these nerves to control? Well, definitely one would be motor activity. Now motor comes in two peculiar flavors in the head. And I only mention it because it's just worthwhile in case it ever comes back with regard to some sort of embryological disease. that there are these somatic motor and branchial motor. So embryologically, there are these very odd little structures called the branchial arches. And that you understand that they're there, I think is important. And that they give rise to a variety of different structures, including skeletal muscle. So these little cells within these arches clearly must be migratory. They're going to migrate up to the head. And they contribute to the formation of lots of structures, including skeletal muscle. So if you look at the two muscles I've talked about here, there's nothing intuitive about this. There's nothing saying, oh, I get one versus the other. This is just the way it happened. But the muscles of the tongue, embryologically, are different than the muscles of facial expression. That's just one of those curiosities. But the one thing that they have in common is they're both voluntary. So these are skeletal muscles. So when I speak, I'm using my tongue voluntarily. And when I smile, right, that's voluntary. I choose to do those things. So the muscle we're talking about is skeletal, and therefore it must be voluntary. That's not to say that there are not involuntary muscles on the head and neck. They're just very few and far between. So have you already done the histology of like the salivary glands? Does the word, let me ask you this, does the word myoepithelial cell ring a bell? Myoepithelium. Right? Well, in glands, right? If you think about glands make, for instance, the salivary glands are making digestive juices, right? So how do you get those fluids out of the salivary glands and into the mouth? Right? Well, these little myoepithelial cells that kind of squeeze the acini and push the fluids out. Well, those are muscle cells. And to make them work, you need something activating them. So those are considered to be smooth muscle cells. So the glands have smooth muscle cells. Turns out there's some smooth muscle cells in your eyelid. We'll talk about those very specifically later on. Now, this is a bit odd though, right? So we're talking about the head and neck, and here I have cardiac muscle. Well, it turns out one of our cranial nerves leaves the head and goes into the body and is important for the innervation of the heart. And that's vagus. Vagus is a wanderer. And the vagus nerve actually is responsible for the involuntary, part of the involuntary innervation to the heart. So, those are our motor modalities. What about sensory? What would we want from the face? What would we want to actually bring back? Well, a lot of them make a lot of sense, right? So if you think about just general sensory information, and the word somatic again is kind of referring to it, its embryological origins. But if you think of what it actually is doing, so general sensory information, things like what? Pain, temperature, touch, right? Those are obvious, right? Your eyes are closed, someone touches your face. You want to know where their finger is pointing, right? If you feel heat or something cold against your face, you want to be able to pinpoint exactly where that information is coming from. Position would be, again, the idea about being able to discriminate between two dots, like two pins being applied to your head. What else do we actually have here? Vibration. Well, the vibration would be definitely coming from the sinuses, maybe even from the meninges. And if you think about it, there's one aspect of proprioception or a joint. So what is the only moving joint of the head and neck? If you think about it, just not the vertebral column, but just this thing up here. What's the movable joint? All right, temporomandibular joint, right? So clearly you need to be moving that the way you want it to move, right? Special sensory information are your special senses. Olfaction, vision, hearing, and vestibular sensation is what? Balance, right? Eyes are closed, you clearly know you're standing upright. Someone pushes you back, you know the inertia is backward or forward with your eyes closed. So, vestibular apparatus. There's a bit of visceral stuff going on, and visceral is kind of the inside stuff of the body. And we're going to see how, again, this cardiorespiratory and digestive function, and that seems very odd for cranial nerves, right? Digestive, right? But we only have that one nerve that does this, and that's vagus, so we don't have to worry too much about that. And last, visceral sensation is taste. So taste is a little different from the special somatic. It gets put down in more of the special visceral. Now, I'm not going to ask you about visceral versus somatics. I just put these terms up there in case that someone who comes along later is very hung up on these terms. I'm not. The fact that you understand the type of motor information you want to send to the face, to the head, right? The type of sensory information you want to get back, right? So you understand about what's going on. Those are the important things, not this nitpicky designation. And so you already know special sensation, taste, olfaction. There's just this division here between somatic and visceral. And of course, pain, temperature, vibration. Those are your general sensations. So here we go. Now, what I'm going to do with each nerve is tell you the really critical thing about the nerve. We're going to make sure we have a clear understanding about what the nerve does, and maybe something just interesting, And olfaction is definitely the first place I want to tell you something really interesting. So every now and then, I'll pepper things in there for scholarship. And when I'm making it, not so much scholarship again, if this was a neuroanatomy course, but scholarship for you in your clinical practice. Okay, so. All right, cranial nerve 1, olfactory, I think you get it, the olfactory nervous system, right? The one thing, though, I got to tell you that a lot of students get hung up on is the fact that this odd little structure at the base of the brain, these olfactory bulbs, people think that's the first cranial nerve. It is not. The first cranial nerve are the olfactory neurons that are found in your nasal cavity. And there are millions of them. And they send very slender little axons back that innervate neurons within the olfactory bulb. So the first cranial nerve is not this. It is really a collection of millions of these things in your nasal cavity. So we know that they're basically picking up the sensation of olfaction, relaying it back. And you know the fact that smell does not occur in your nose, right? That's merely a chemical transduction, electrical signaling, right? Your knowledge of what you're smelling is up in your cortex. You're pulling that information. These molecules give me the answer of banana versus the other molecules give me the answer of ammonia. Right? Two very different smelling things. Now, the really cool thing about these neurons, and this is, I think, something really important for you to know, is that these are your only neurons in your body that you're constantly making new ones for your entire life. We're always making new olfactory neurons. Very cool. So there must be stem cells out there in your nose that are making new neurons all the time. And think of the challenge then that these neurons have to send new axons back, right, to make the right circuitry so that you continue through a lifetime to know the difference between a banana and ammonia. That's the curiosity of these neurons, but I'll tell you something really interesting about olfaction. That's come out in the last little bit. And that is that when you're in practice and you meet a person in their 50s and their 60s and they're starting to complain about tremors or an inability to move as fluidly as they once did, and then you work them up and seems like this could be an early Parkinsonian patient. Or you meet an individual with full-blown Parkinsonianism, right, for the first time. And you ask those individuals to describe what's going on. And when people, have tremors, right, family members go, ooh, your hand is shaking a lot now. Or an inability to do up buttons, right, fine motor activity, their face looks a little blank. All sorts of things lead up to Parkinsonism where people go, there's something wrong. Or you yourself know there's something wrong. You go to your doctor and say, I feel there's something wrong with me from a motor activity. It turns out that people will go to the doctor then. But you ask these people about their sense of smell. Parkinsonian patients, over 90% of Parkinsonian patients now will tell you that they probably have not been smelling properly for 10, 15 years. Something is going wrong here. And we don't know what the link is between Parkinsonianism and olfaction, but it seems to be maybe an early indication that something is not quite right with the nervous system. Because if 90% of them have it, and they all go back, and that's the problem, right, with olfaction. Patients are not going to come to you and say, I can't smell anymore. And the reason is because taste and smell combined in your brain, right, to actually give you the entire flavor of what's going on. So especially with food, right, I mean, you actually have these two sensations. So people don't come to a doctor complaining about an inability to smell. But tremors, an inability to do fine motor activity, they'll come talk to you about. So it's interesting. Something's going on there. So you think, human beings, they don't really care about smell too much. And that's very, very true, right? But maybe something cool is going on here. And what makes the story even cooler is the fact that if you catch Alzheimer's patients early enough, where they have recollection of what has been going on the last umpteen years, they too will complain. About 60 to 70% of those will say, olfaction is not working properly, smell, But Parkinsonism is over 90%. So something really cool is going on there. Now, a patient comes in and says, I'm not smelling properly. Don't tell him you have Parkinson's, right? Don't say you're on your way to become Parkinsonian. That's not the point of this. We don't know yet what the link is. But it's a cool one. All right. So as much as olfaction is something that people will live 10 years without and not complain or tell anybody about because it's not that important, vision is the complete opposite, right? I mean, human beings rely on our vision for everything, right? Our existence. And it's so critically important. So when things go wrong in your visual abilities, right, you notice something's wrong, and you go to see the doctor very soon. So, cranial nerve number 2, optic. Now, like a lot of our neurons, there are a lot of our pathways, right? There's this idea of sharing information. So when we think about picking up the visual information in the eye and understanding what I am seeing, when I'm understanding you now, all your faces, right, the room, etc., that's back here in my cortex. Again, vision is to get the information from point A, your eye, back to the cortex, is a 2-neuron chain. The second neuron is different, right? That's no longer the cranial nerve. So we're dealing with the cranial nerves. We're going to have a lecture on vision. But the idea here is the fact that what is the cranial nerve? And the cranial nerve is the one, for optic, that connects the eyeball to the brain. Now, when we look at the human eyeball, the retina actually has this cup shape. And there's a nasal aspect to the cup and temporal. So if you think about your nasal bone, your temporal bone, right? So the retina has a cup, and there are 2 parts to it, nasal and temporal. And in fact, the light is coming in from the nasal, medial, or lateral aspects. And because everything switches around, it's really easy. So the nasal aspect of the retina gets temporal light, and the temporal aspect of the retina gets nasal light. That's what's being shown here by those crossed lines, right? So vision, so if everyone wants to just watch for a second. Vision here, right? It's in the lateral aspect. Sorry, yeah, this hole is like terrible. Oh, now I got it. So vision here, the lateral aspect of your retina. Vision here is from the medial aspect of the retina, okay? So when you ask people to do this, right, can you see my hand, right? You start out here, and you keep looking at me straight, can you see my hand? Yes, 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 right? You're using different sets of neurons within each of the retina, okay? So it's just a really easy thing. The nasal retina, it's temporal light. The temporal retina, it's nasal light. Nice crossover. Now, what makes it really cool and why it's important is because there are we have these 2 populations of neurons, nasal and temporal retinal neurons. And if you think about it, their axons are all streaming into, right, the optic nerve. So we think about now, what is the information? What are we doing here? We're getting visual information to convey back to the central nervous system. So the neurons are located in the retina, and their axons are extending into the optic nerve because we're getting we want to send the information to the brain. So if you think about the optic nerve itself, each one, the left and the right, is carrying all the visual information from that particular eye. So through trauma, like a car accident, with a penetrating wound into the orbit, right, that might sever the optic nerve, you end up with complete blindness. That's what's happening here. Because all the axons within the optic nerve have been severed. Okay? That's going to be more important on the next slide. Now, why did I specifically mention that little schematic of the embryo and show you that out, right, that little stalk on either side, and say, very early on, embryologically, the optic nerve develops as part of the central nervous system. Because the axons that are in here, and this is absolutely critical, did you know this? The axons that are in here are myelinated by oligodendrocytes, not Schwann cells. Oligodendrocytes. There are astrocytes in here, which makes it part of the central nervous system. Remember we talked about how there was a poor regenerative capacity to the central nervous system. Well, that poor regenerative capacity also applies to the optic nerve. You sever this nerve, you crush it, you damage it, regeneration is unlikely to occur. You sever, you crush the median nerve, reconnect it, remove the lesion, whatever. Slowly with time it'll regenerate. Sciatic nerve, ocular motor, all right? Regenerative capacities in peripheral nerves is really good compared to the central nervous system. And the optic nerve is part of the central nervous system, myelinated by oligodendrocytes. Very important. Now, we think about these two populations of retinal neurons, nasal and temporal. Each of them are sending their axons back to the optic nerve. And now we get to a different structure, and that's called the chiasm. And remember this whole concept of crossing. Well, now we really get into a situation where some axons cross the midline and others do not. Well, which axons are crossing the midline? Well, it turns out that the axons crossing the midline are all your nasal axons. So if you look at this schematic very carefully, right, here's the nasal part of the retina. We follow its axon in here, and it crosses at the chiasm. So the visual information from the left nasal retina ends up on the right side of the brain. But the temporal part, if you look at it, this temporal part here, the axon continues, does not cross, and remains on the same side. So are you familiar with the terms ipsi and contralateral? No? Important words. Look them down. Ipsilateral on the same side. So ipsilateral, same. Contralateral, opposite. So, what's going on here? These nasal axons, right? Start here with the cell bodies, extend to the optic nerve, come to the chiasm, and cross. So the visual information now is contralateral for the nasal neurons. The temporal neurons, on the other hand, both left and right, their axons enter into the optic nerve and remain ipsilateral on the same side. Why is this important? Well, it's important for us neurobiologists because you can actually think what a cool event must be happening, right, embryologically. Right? You get a wave of axons that get to a point, and the signal must be everybody cross. And another group of axons get to the same point, and the signal is don't cross. And in fact, it turns out that these axons get there, the nasal ones, not unique, no, but it's just cool. Nasal ones get there first, the signal is crossed, and when they've all crossed, the temporal ones get there and the signal is gone, and they stay on the same spine. It's very cool. Anyway, very important decision to make, to cross or not to cross. But why is it important? It's important because of how lesions will manifest themselves if you damage the optic chiasm. Now, what could possibly damage the optic chiasm? Well, right behind it actually sits the pituitary. And you can get these really nasty, benign, not malignant, benign, but nasty, pituitary adenomas. Meningiomas, tumors of the meninges like to occur here as well. And they literally push down on the chiasm. Now, you would be presented with a patient whose axons are not working. So why do axons fail to work? This is actually a good core concept as well. Why do axons fail to work? So if you can imagine a space-occupying lesion pushing down on a bundle of axons, you're not severing them, right? It's not trauma like this, right? That was trauma. Cut, right? Rather now, the tumor is pushing down on the axon, right? It's distorting the structure of the axon. The axon is not severed. Well, by doing that, the electrical signal cannot flow properly. I mean, it just turns out the fact that if you distort axons, they don't work. And if you, probably by pushing down, you're interfering with their blood supply. Axons need oxygen and glucose too. And if you interfere with their blood supply, they won't work. So this compressive lesion, right, needs to be removed. And surgeons can go in and right through the middle here and get in there and take these things out. And fortunately enough, what you do is the axon not having been severed, you've now removed that space-occupying lesion, right? And so that pressure that you exerted on the axons has now been lifted. And with time, function will come back because the axon has not been cut. Now, how will these people present? And this is what it's all about with regard to the anatomy of the retina. If we think that all the axons crossing at the chiasm are the ones bringing out visual information temporally, then that is what must be affected. And people will complain the fact that they really can't see things from a temporal point of view. So you get this idea bitemporal, because it's happening both in the left and the right eye, bitemporal hemianopia, because it's half the visual field. So now you do the same test. So you say to the patient, look at me and watch my hand. And they go, I can't see it. I can't see it. I can't see it. Oh, there it is. Yeah, I see your hand. I see your hand. No, it's gone. I'm not seeing anything here. Right? This idea of bitemporal hemianopia. And that's because you've damaged the axons that cross the midline at the chiasm. So these axons now have gone from the optic nerve, where they're all on the same side, the optic chiasm, where 50% cross and 50% do not, and then we end up in the optic tract. And if you look at the optic tract, we now have axons from the left eye and the right eye in both the right and the left optic tracts. Together, all of these are part of the first cranial nerve. Unfortunately, we only give name to one of it, and that's the optic nerve. And you can see why we have, because remember, we haven't found another neuron yet to synapse with, right, to share the information. It's still the same neuron, retinal neuron. Its axon in the optic nerve, chiasm, tract. So this thing here is the tract. And you can see why we have to give these things all different names, because of the visual information conveyed in those parts. Because the visual information in the optic tract on the right, is very different from the visual information that's being traveled in the optic nerve. The optic nerve is only carrying information from the ipsilateral eye, whereas the tract now is bringing information from both the right and the left eye, and vice versa, right? So you have to give this one back here a different name. Ultimately, they end up innervating neurons in this structure here that I've blocked out because we don't need to do it today. This is about the cranial nerves. movement of the eye. First nerve. Number 3, oculomotor. So, have you done anything about the eye? So if I say lateral rectus, you've done the muscles. Excellent. So you've done nerves as well. So basically, I'm just going to fill in a bit more information. Okay? So, when we think of ocular motor, it innervates 4 of the 6 extraocular muscles. Superior rectus, inferior rectus, medial rectus, and inferior oblique. Great. And you got it. Now, also traveling in ocular motor are axons that innervate the levator palpebrae superioris. Have you heard of that muscle before? Ah, great. So, levator, to do what? To lift up? To levitate, right? To lift up. Palpebrae, anybody know what that structure is? Your eyelid. And superioris, you have an upper eyelid and you have a lower eyelid. Levator palpebrae superioris. There's a skeletal muscle in your upper eyelid to keep it up. Eyelids are really cool things. They can tell you a lot about what's going on. So the fact that there is somatic innervation of skeletal muscles in your upper eyelid, and that's the levator palpebrae superioris conveyed by ocular motor. Now, the eyelid is cool because we do not spend a lot of time being consciously aware of keeping our eyelids up, right? That's voluntary activity, right? They just stay up. I mean, we can close them, right? And we can open them. And when you really open your eyes a lot, chances are you're actually using more of your orbicularis oculi. But you don't spend a lot of time thinking about it. So eyelid is going to be very important in testing one of the cranial nerves. So if you think about it, if ocular motor is not working, we have a denervation of these 4 muscles, right? And so the eyeball is going to be displaced on the one side, right? But in addition to that, you'll see the patient has what? A droopy eyelid on the same side. Now, the droopy eyelid is not nearly as upsetting as the eyeball being pulled in an opposite direction, right? Not being centered. And you will notice that as you walk into the patient, because their one eyeball is looking at you directly, and with an ocular motor lesion, their eyeball is turned down and out, right? It's down over here to the unopposed actions of the other 2 muscles. But on that same side, you'll notice a droopy eyelid. So that's levator palpebrae superioris. Now, as much as we have motor activity, voluntary motor activity, okay, going on here, we also have involuntary motor activity being conveyed. So up until now, the 2 cranial nerves we've done have had one function each. Olfaction is only about smell. Optic was only about vision. But now we have our first cranial nerve that has 2 functions. One is motor that is voluntary, because you tell the patient to look up, to look down, left, right, all of that is voluntary. When I'm watching something, I'm voluntarily moving my eyes to keep focused on the activity that's going on. Voluntary. The eyelid's a little different, but nonetheless, it is also innervated by ocular motor. Involuntary activity is the domain of the autonomic nervous system. And one component of the autonomic nervous system, as you're going to see, are the parasympathetic. So from a pharmacological point of view, physiological point of view, you have an idea about sympathetics and parasympathetics, right? So what we're going to do is more about the neuroscience and why you need to know about these things clinically. So why do you need to know these things clinically? Well, these parasympathetic fibers traveling in ocular motor convey pupillary constriction. And last I checked, a lot of doctors like to shine light into people's eyes and to see if they contract, right? Well, why are you doing it? You're testing the functioning of ocular motor, right? The fact that it is able to cause pupillary constriction. So when you shine light into someone's eyes and you see their pupils contract, that is the motor activity, involuntary motor activity, being conveyed by ocular motor. And why is it involuntary? I have no control over the contraction or the dilation of my pupils. Right? No control. The ciliary muscles, same sort of thing, are little muscles that are doing accommodation of the eye. And when you actually want to really feel how they work, just take your finger and just keep focusing and focusing and focusing. And as you keep bringing it closer, you almost feel your eyes getting a little thick, right? As you do it. Well, those are the ciliary muscles, keeping your eye focused on your finger at very, very close range. So for near vision. And again, you're making them work here, but they're always working involuntarily. So we're going to get more into that. But the concept here for ocular motor is very clear. It's the first, not the only, but it's the first cranial nerve we've encountered so far that has more than one function. It has a voluntary motor function, and I've got to know all 5 muscles, yes. And it has an involuntary motor function, and yes, you absolutely have to know it's all about pupillary constriction. To make the eyeball move, we need 2 other muscles to work as well. And the nerves activating them are trochlear to the superior oblique and abducens to the lateral rectus. Now, trochlear gets its name because there's a little hook-like process that the superior oblique is associated with. And this little hook is actually called a trochlea. And that's why we get the name trochlear nerve for superior oblique. And for the lateral rectus, the nerve is referred to as abducens because lateral rectus is abducting the eyeball. It's pulling it out laterally. And that abduction gives rise to the name of the nerve, which is the abducens. So, you know all about these 6 extraocular muscles. We have 3 nerves that control the movement of the human eye. We have these 4 muscles that work in a very easy, straightforward aspect: superior, medial, inferior, and lateral recti. Their names give away as to which way the eyeball moves. Superior and inferior oblique are a little different. It's more about this intorsion and extorsion of the eye. But the bottom line of it is that all of these nerves need to be working in sync to actually have the fluid movement of the eyes for all mammalian species. And then not to forget that when it comes to ocular motor, it's got some extra functions. So trochlear and abducens go back to this concept of one simple function. Right? It innervates one muscle and it has one function. And that's all that those nerves do. Okay? So we'll talk about those. Okay, so yeah, we'll talk about those when we do vision. Great. So I think we can get trigeminal done, and then we'll take a break. Then you have another lecture, and then I come back. So we'll be able to get it done today. All right. Trigeminal. So we jumped ahead there, right? We went 3, 4, and 6 because they're related. So back to 5. 5 is trigeminal. 5 is really a big nerve. And it's big because it has a huge motor component and it has a huge sensory component. So, you think about one nerve now, trigeminal. It's sending information out and it's bringing information in. The logical way of thinking it, the outflow of information has to be motor, and the inflow of information is about sensory. And what type of sensory? Well, it's the general sensory. And look what we've got here. Pain, temperature, touch, vibration. Joint positioning. There's that temporomandibular joint, right? And it's not just for the surface of the face, the head, right? It's also for what's going on inside your mouth and your sinuses as well. And for the mouth, we're even talking about the anterior 2/3 of the tongue. So when we think about the anterior 2/3 of the tongue having to do with pain, temperature, trigeminal is conveying that information back. So from the anterior 2/3 of the tongue. Motor activity is all about mastication. Anybody know what mastication is? Chewing. Medial lateral pterygoids, temporalis, and masseter. So again, this is not gross anatomy. Right? I'm not going to ask you to find those muscles. As long as you know them, that's fine with me. And there are a couple of miscellaneous muscles here as well. that are really not all that important. But as long as you understand that when you think about the movement of the jaw, it's trigeminal, and sensation of the face, including the anterior two-thirds of the tongue, it's all about trigeminal. Now, so these schematics then show you what the nerves look like, what's going on. Now, if you think about it, if it's motor activity, there's got to be some group of neurons in the brain that are making, things move, right? So where are those neurons in the brainstem? Not for today, right? Because we're thinking about the trigeminal nerve, not so much the nuclei in the brainstem or the brain itself. Sensory information, yes, we're picking it up, but where's it going? Not today. As long as we recognize that the trigeminal nerve is all about bringing sensory information in. Now, the nerve is so large that there actually are 3 distinct divisions to it. And they get named V1, 2, and 3. That's trigeminal. So these V's stand for, not for V, the letter V, but for Roman numeral 5. So there's 1, 2, and 3 divisions. So we actually have an ophthalmic, maxillary, and mandibular. And they have very specific territories. So if you think about ophthalmic, the eye, pretty good. Forehead and nose thrown in for good measure, but the eye. Maxillary, right? Your cheekbone. That's the maxilla, right? So this part here and your upper lip is all the maxillary, and mandibular, obviously, for the mandible. So the sensory information being conveyed from the mandible versus the maxilla versus your forehead, right, are all being brought back by trigeminal through different branches. But they converge into the one nerve. So if you see these rootlets here, bringing information in, bringing information in, bringing information, and they converge into the one rootlet. Now, last concept, and I'll stop. What is this large structure here? So, ganglion. Do you know the term ganglion, what it means? Ganglion is a collection of neurons outside of the central nervous system, outside the brain. So we have trigeminal ganglion, autonomic ganglion, dorsal root ganglion, right? So they're a collection of neurons outside of the central nervous system. Within here, we can find these oddly shaped pseudo-unipolar neurons, these sensory neurons. So they have to have a process going out peripherally to pick up the information, and they have another process that goes into the brain to share that information. And it's within the ganglion we actually find the cell bodies of these neurons. Again, represented by a little dot, and the lines represent their axons. So we think about sensory information from the face. It's got to be picked up. Sensory information funnels through the ganglia and then en route to the brainstem where it's processed. The motor information, you think about mastication now. This is an easy one to think about. Think about mastication, moving of the mandible. Which of those 3 roots should carry the motor component? Well, probably the one with the name, right? Mandibular. So the motor outflow of information only goes through the mandibular branch. It does not go through maxillary, nor does it go through ophthalmic, because there's nothing up here, right, that they're worrying about innervating from a motor point of view. The motor fibers all come through the mandibular division and then splay out to innervate temporalis, masseter, and the 2 pterygoids bilaterally on each side. So remember that there are pairs of these ganglia as well. So there's a left and a right trigeminal. So here we have one nerve now which is doing 2 very different things. It has a motor and a sensory component. The motor is for the movement of the mandible, that movement of the temporomandibular joint, and the sensory, because the face is so important, right? The human face is so important to actually know exactly where the sensory information is coming from. There are 3 large divisions that carry massive numbers of axons out here to innervate the forehead, the eye, the nose, ophthalmic, the maxilla, right, maxillary, and the mandibular. And then with the maxilla and the mandibular, think it's not just peripheral, it's not just superficial rather, but it's also inside. So when you think about the teeth and your gums, your upper teeth and the gums, maxillary, lower teeth and gums, mandibular. So at the dentist chair, you feel they're picking away, ouch, right? Depending on if it's up or down, two completely different sets of nerves, but associated with the one large cranial nerve, trigeminal, number 5. All right, so let's stop there, have a little bit of a break, and I will see you in an hour from now. Evidently, that's what happens.